Thank you very much to the organizers for inviting me. Can I have my slides, please? Okay. So device-based heart failure therapy. So this is really the next big thing in interventional cardiology after coronary, peripheral, structural, and valvular. And we are actually conducting a conference just about these procedures. And last year we had more than 70 new devices dedicated to treat heart failure patients. The primary treatment modality for heart failure is, of course, medical therapy. So why do we need interventions to treat heart failure patients? Well, what are the potential advantages of an interventional strategy in heart failure? Sometimes medical therapy is not effective, as you know. Sometimes interventions may be able to eliminate the cause of heart failure. It may be possible to interrupt the vicious cycle. There may be fewer side effects than with some medications, and obviously no problems with compliance. So these are the advantages of a device-based strategy. So what kind of heart failure interventions are available? Valvular interventions, interatrial shunts, interventions targeting the LV, extracardiac interventions. Let's start with the valvular interventions. As you know, secondary or functional mitral regurgitation is part of a vicious circle. It starts with LV dysfunction and LV dilatation. Then you have functional mitral regurgitation. Then you have, again, LV dysfunction and dilatation, and this increases functional mitral regurgitation, and this then increases LV dysfunction and dilatation. Obviously, eliminating of mitral regurgitation may interrupt this vicious circle. There's no question that we should always start with optimal medical therapy, but optimal medical therapy is not optimal. In fact, it is terrible. Look at the prognosis in heart failure patients under medical therapy. Mortality under medical therapy is 70% in 5 years if FMR is severe. Survival is reduced even if FMR is only mild, as you can see for these statistics here. So maybe we should intervene much earlier. So the questions are, can we treat FMR by interventional techniques? Can this be done safely? Does it improve symptoms or even survival? And could this interrupt the vicious circle? 3 catheter-based techniques are available: the MitraClip, Pascal, and Carilion. Can we treat FMR with these techniques? Oh, yes, we can. This is an example of a MitraClip treated in 2009 and follow-up in 2014. This is another example before and after catheter annuloplasty with a Carilion device. So yes, it does work. Is it safe? It is not safe. It is very safe. I will give you some trial data. These are the adverse events with the catheter annuloplasty with a Carilion device, and you can see that the cumulative MACE rate is 16% in the treatment group and 18% in the control group. So treatment is even safer than medical therapy alone. And the same is true for the MitraClip. These are data from COAPT. And you can see that regarding all these adverse events, and I will not go through this list in detail, regarding all these adverse events, MitraClip is safer than medical therapy alone. If I would be the patient, I would stop the discussion here and ask for treatment, because there are techniques available which are able to reduce my functional mitral regurgitation. They are safe, safer than medical therapy alone. The procedure may interrupt this vicious circle, and probably most importantly, many other patients have told me that they feel much better after treatment of their FMR. But I'm not a patient. We live in a world where common sense does not count. Randomized trials are the only accepted source of wisdom, at least in medicine. This is different, for example, in politics. So let's look at the evidence, and we have 3 randomized trials looking at these mitral repair techniques. You all have heard about the COAPT technique: 614 patients with heart failure and moderate to severe or severe secondary MR, symptomatic despite maximally tolerated medical therapy, randomized to clip versus plus medical therapy versus medical therapy alone. And you know the results: significant less hospitalizations for heart failure within 24 months, significant reduction of all-cause mortality, and substantial MR reduction in these co-opt patients. Time to death or first heart failure hospitalization correlates with technical success. The other trial was negative. MITRA-FR, 452 patients, they had not been on maximally tolerated medical therapy, randomized to CLIP versus control group. You know the results. I don't know if you already knew it. The results of MITRA-FR surprised everybody, including the MITRA-FR investigators and many non-invasive cardiologists, and these results had been the real reason for the Brexit. Why are co-opt and MITRA-FR different? Co-opt excluded patients with right heart failure, different criteria for severe MR, slightly different endpoints. MITRA-FR patients had larger ventricles, medication was different, and co-opt had better technical results than the MITRA-FR trial. The other device which has been used to treat functional mitral regurgitation is the Carillion device. It's a coronary sinus approach, so you enter the coronary sinus, you put a distal anchor, and then you apply tension, and you apply a proximal anchor, and this reduces the diameter of the mitral valve and reduces MR. This was the randomized, actually sham-controlled trial with this device. The primary endpoint had been change in regurgitant volume at 1 year in the intention to treat group. There was a 22% reduction in treatment group and 1.5 increase in control group. The absolute difference was 10.4 milliliter, and this difference was significant. So this was a positive, sham-controlled, randomized trial to treat functional MR. We saw positive remodeling with Carillion, but not with MitraClip. You can see the change in LV-EDV at 1 year in the intention to treat group. First, reduce FMR, severe MR group. You see a positive remodeling, decrease of LV size in the treatment group. In co-opt, you could not observe that, and obviously also not in MITRA-FR. So this was the only approach which reduces the size of the left ventricle. So yes, we can treat FMR by interventional techniques. These techniques, Carillion and MitraClip, are safe. They are improving symptoms. These treatments may interrupt the vicious circle. In selected patients, they are improving not only symptoms, but also clinical outcome, and therefore they should be offered and recommended in these selected patients. Second group of interventions to treat heart failure, and I cannot cover everything here, are intraatrial shunts. Creation of a small atrial septal defect to decompress the left atrium is the concept. It's a new concept for patients with systolic or especially diastolic heart failure. You know, atrial septal defect causes a left-to-right shunt. This causes right heart volume overload, pulmonary hypertension, right heart failure, all not really good in patients who already have left heart failure, but there may be exceptions. When could an ASD be beneficial in heart failure patients? Well, if the ASD is very small, it will not cause an increase in pulmonary artery pressure, but may result in a decrease of the left atrial pressure. The workload will be shifted from the diseased left ventricle to the healthy right ventricle. And this could be a concept especially in patients with HFpEF who do not have many other options. How the idea of creating an ASD in heart failure patients developed, well, some of you may remember from medical school the Lutembacher syndrome. Patients with mitral stenosis and the concomitant ASD have less severe symptoms than patients without ASD. ASDs have been created by ballooning in patients with mitral stenosis to relieve symptoms before mitral valvuloplasty became available. Later, ASDs had also been created in patients with other causes of left heart failure, including patients on ECMO. How to create an ASD, balloon dilatation, stent implantation, and several dedicated devices, as well as 3 devices which are creating defects without leaving a device behind. The concept is a small shunt can regulate the left atrial pressure, and this could work in heart failure with preserved ejection fraction as well as in heart failure with reduced ejection fraction. This is an animal model looking at systolic heart failure, 21 sheep, and you can see that regarding all these parameters, those animals who received a shunt did better than those who did not receive a shunt. These are some human data. This is the first reduced LAP heart failure trial results. They showed a significant improvement in heart failure class, 6-minute walk test, quality of life, and exercise time. This is with another device, the V-Wave device. Shunting improved functional outcomes in heart failure with reduced as well as with preserved ejection fraction. And this is the third device which have been investigated, the AFR device. And you can see that they could show improvement in diastolic as well as in systolic heart failure patients. To summarize the completed interatrial shunt trials, there was striking consistency across multiple devices and trials demonstrating a high implant success rate, excellent procedural and device safety, improvements in heart failure class, quality of life and 6-minute walk distance, low rates of mortality and heart failure hospitalization, suggesting an impact on clinical outcomes. The third group of device-based therapy of heart failure is attacking the ventricle. The Accuquench ventricular repair system, or Ancora, was initially developed as mitral annuloplasty device. It reduces ventricular dimensions, reduces ventricular wall stress, and improves ejection fraction. You can see an example here. Actually, you can see that this device is not at the level of the annulus. It's about 1 centimeter or 2 centimeters inside towards the left ventricle. That's why it's a ventricular approach. And here you can see an example. This is baseline, and this is after 6 months in one of these patients. The other attempt to treat the ventricle directly is for ischemic heart failure. This is the Revivant TC concept. It's to exclude the scar from the remaining viable myocardium, reducing volume and improving cardiac efficiency via wall stress reduction. It's a hybrid approach with thoracotomy and transvenous access. And here you can see an example with MRR before and after. You can see that the LV aneurysm almost has disappeared. The third approach is still in an early stage, papillary muscle approximation. As you know, functional mitral regurgitation is not the disease of the valve itself. It's a disease of the left ventricle. And there's a surgical technique to bring the papillary muscles together with a Gore-Tex tube. And this is now also used in animals so far to treat heart failure patients. And you can see an example in the sheep model. We can see the band is surrounding the papillary muscles and reducing the size of the left ventricle. And finally, there are some extra cardiac interventions, and they all have to do with autonomic modulation, renal denervation, baroreceptor stimulation, endovascular baroreflex amplification, aortic autonomic neuromodulation, and greater splanchnic nerve ablation. Why could renal denervation be beneficial in heart failure? You know this for treatment of hypertension, but sympathetic overactivity in heart failure correlates with functional class, as you can see here. Those patients with functional class 4 have very much activated sympathetic tone. And there are already randomized trials for this patient group. This is the Oclumoc trial, and you can see the change in NT-proBNP in a randomized trial looking at the efficacy of renal denervation in heart failure patients. Then we have the device-based baroreceptor stimulation. Some of you are aware of the electrical baroreflex activation. It suppresses sympathetic activity and augments parasympathetic activity. And there's now also an endovascular approach to stimulate the baroreflex mechanism. This is the endovascular baroreflex amplification with the Mobius device. What is the Mobius device? It's a self-expanding rectangular nitinol implant. It retains pulsatility of the vessel wall. It reshapes the carotid artery without expansion, and baroreceptors are activated by stretch. And you can see that the implant creates a larger effective arterial radius and increases arterial wall strain, and this stimulates the baroreflex mechanism and reduces sympathetic tone. So it's effective in treating hypertension. These are data from the hypertensive trial, the CALM-FIM European cohort of 30 patients and additional 89 patients. You can see it's a long-lasting effect on blood pressure up to 3 years and beyond. And we have used this technique to treat heart failure patients, looking for patients with systolic heart failure, typically in heart failure class 3, in need for treatment options beyond medical therapy and CRT, but not candidates for LVAD and transplantation. You can see the key inclusion criteria on the right side of this slide. This shows you the implantation. It's very much straightforward, like carotid stenting, but much, much easier because there's no plaque, no stenosis. Those patients would have been excluded. So you can see the implant is implanted like a self-expanding stent, and then you see the final angiogram after implantation of this device, which is sitting at the carotid bulb. Now look at the results. These are 18 patients with 6-month follow-up, and regarding all these parameters, there was significant improvement. Quality of life increased, 6-minute walk distance increased, heart failure class improved, LV ejection fraction increased, and NT-proBNP decreased. All these differences had been significant. And finally, ablation of the greater splanchnic nerve. So this is targeting those patients with preserved ejection fraction. This is a frequent form of heart failure, as you may know, with a poor prognosis. Many of these patients have normal filling pressures at rest, but a marked elevation of PC wedge pressure with exercise. What happens in these patients? Well, the increased LV filling pressure is caused by a volume shift. This excess blood volume comes from the splanchnic vascular bed, which is the body's main blood reservoir. The splanchnic vascular bed is highly innervated with adrenergic nerves, and small increases in vasomotor tone results in large fluid shifts and high pressures due to impaired compliance of the left ventricle and the left atrium in these heart failure patients. So it's a volume shift from the splanchnic bed to the circulation. The splanchnic vascular bed is innervated by the greater splanchnic nerve. It originates at the thoracic sympathetic ganglia, crosses the diaphragm to innervate the celiac plexus, contains sympathetic and also pain fibers. Increased activity results in selective constriction of the splanchnic reservoir and increased venous return. Decreased activity results in selective dilatation of splanchnic reservoir. So there's a technique, surgical resection of the greater splanchnic nerve has been used for decades to treat resistant abdominal pain. Very few side effects if performed unilateral. The unilateral procedure retains the body sympathetic response for emergency use. Resection of the greater splanchnic nerve may reduce the volume shift from the splanchnic vascular bed to the circulation. And this has been tested first surgically in 10 patients with HFpEF. No adverse events occurred related to the greater splanchnic nerve absence, and they showed durable 12 months follow-up results, and you can see reduction in PC pressure, improved functional heart failure class, improved quality of life, and extended exercise duration. How to do this without surgery? The Satera ablation system is an over-the-wire transvenous system. It targets of the procedure is the right greater splanchnic nerve. And you can see significant improvement in 3-month quality of life, heart failure class improved, as well as quality of life improved, significant improvement in 3 months, 6 minutes walk test, and NT-proBNP. So to summarize these results, right-sided GSN ablation is a promising therapy for patients with diastolic heart failure. This is the first transvenous approach to achieve selective GSN ablation for treatment of heart failure in an interventional procedure. The study demonstrated that permanent right GSN ablation in HFpEF is well tolerated and results in clinical meaningful improvements in quality of life and access capacity. So in summary, heart failure interventions will be the next big wave in interventional cardiology. Several technologies are already approved and available, like the MitraClip and the Carilion device, and more than 75 other technologies are in an early stage, and they will be presented at our heart failure conference in December in Frankfurt. Thank you very much for your attention.